So today I have the privilege of interviewing Dr. Jennifer Miranda. We're going to talk all things health, wealth, life, and whatever else comes up. As you know, I'm pretty random, so here we go. So, Dr. Miranda, you were raised in Miami, correct?
Yes, born and raised.
Okay, where did you attend high school? I have to ask the Miami question right off the bat.
I went to Carrollton for actually what felt like my whole life, from 1st through 12th grade.
Okay.
I loved it.
True Miami native. And then you went where to college?
Then I went to Harvard University for undergrad.
So correct me if I'm wrong, but what's that called when you tell someone you went to Harvard?
Oh, I mean, it's funny. When we were in college, there was a joke that people would bring it up on their own to be able to say that they went to college, and it was called dropping an H-bomb.
Dropping an H-bomb.
I'm not too keen on that, but it exists.
But definitely. So I think, one of the things I want to discuss too, so Dr. Miranda is the brightest and most brilliant doctor there is here. Learning for her has been easy. Top of your class in college, top of medical school, top. But I do think, people think things look really nice and really easy all the time. Is that where you want to go to school? Was that your number one choice?
Actually, I really wanted to go to Georgetown, if I'm being perfectly honest. I had visited it with the close-up program that they take high school kids to, and I loved it. I thought it was beautiful. I felt like it was my place. I had also visited with friends the Harvard campus, and I also thought it was very beautiful and impressive, but really I wanted to go to Georgetown. But Harvard was much nicer with their financial aid package, and so they won my heart.
Did you go back and tell Georgetown anything about that?
No.
But they didn't offer you the same package?
No, they said that they couldn't match that. So.
Well, there you go. So you did ask something. So I think sometimes, and when we talked about this before, the world conspires for you. And there's nothing wrong with Georgetown. In fact, the other physician here went there, and it's a fabulous school. Fabulous school. However, I think the world's most recognized college is definitely Harvard. And so by that happening, I think that has helped with certain patients that want to come here and other people that went to Ivy League. I think that's helped a lot with building your practice. Would you agree with that?
I think that's true. Even though I didn't get my medical training at Harvard, I think people lend a certain amount of credibility to you as a person if you went to an Ivy League school such as Harvard or one of the others, or they feel like maybe you are more thorough or more knowledgeable because of the education. So I think so.
I think one of the things that really separates you, because I've had the pleasure of being able to call on as a sales rep dozens and dozens of different doctors that went to Ivy League. They're not all personable, or they don't have good bedside manners. So I think that's what differentiates different physicians. And I think you kind of bring all those together, which has allowed you to open up Pure Executive Health and Wellness 11 years ago, almost 11 years ago.
Yeah.
So I do want to talk a little bit about that. So you get into your second school, which is, to me, comical. Like Harvard, dropping the H-bomb is pretty wild, and you were able to do that. Did you have any adversity at Harvard or anything that kind of changed the course of where you went in life?
So not in terms of educationally, no. I mean, I loved my major, which was history and science. So I learned about American history and about the history of science, the history of American medicine, and made great friends, and all of that was wonderful. I did have, personal issues with my family. My father passed away when I was at Harvard in my junior year, so I think that did affect where I decided to apply for medical school, where I decided to accept when I got in to medical school, to be closer to family.
And is family really important to you?
Oh, absolutely.
Yeah. So that also was something that changed your trajectory, because I know you got into some other colleges and you would have loved to have gone there, but I know that kind of changed the course of where you went to school.
I think so. I definitely wanted to be close to home, be here to support my mom and my siblings. And I think it was one of the best things I ever did.
Did you want to be a doctor before that?
Yes, I always wanted to be a doctor. I don't remember when, somewhere in grade school. In first grade, one of the nuns at Carrollton told me that I would make a good lawyer. But maybe that's because I was able to debate, let's say. But ever since I can remember, I wanted to be a doctor.
So let's fast forward a little bit. I think people need to understand some of the adversities people go through and things of that nature. So you go to the University of Miami Medical School. You did very well there. Then again, did you stay? You stayed for residency for the same reasons?
So I actually loved the attending physicians, the program, the teaching, and the kind of the diversity of patients that you see at Jackson Memorial Hospital, for residency. So I definitely wanted to go there once I realized how wonderful of a place it is for learning medicine, and so much so that actually I did what we call like a suicide match, which is that I only ranked Jackson on my list of places I wanted for the residency match, and I told them that I was doing that, and I just closed my eyes and said, well, it's either them or nothing, because that's where I want to be, and it worked out.
I did not know that. It did definitely work out. And then you did a chief year at the end.
Yes, they asked me to do a chief year, which is like a junior faculty position. They pick a few of the residents that they felt were exceptional and ask you to be in charge of the residency program with them, and also be a teacher as like in a junior faculty position.
And they pay a little bit above minimum wage for that position.
Thankfully, they pay enough that I could get an apartment and rent one for the year, for sure.
See, what I think people don't understand, and people should kind of understand, is like to get to certain places, most people sacrifice, right? So like what they didn't realize is you did medical school, you go into debt, right?
Oh, yes.
Hundreds of thousands of dollars.
Still paying my student loans.
But then when you're a resident, you do get paid, correct?
You do. You get paid a salary. I mean, if you divide it up based on the hours that you're there, it's not a great salary, but you do get paid, and you need to, because you have to live and eat and drive to work and all the things, so absolutely.
And back then, call was how many hours?
So yes, our hours were different. They were changing, in the beginning of my chief year, they started changing hours, shortening call and shortening shifts. But when we would do overnight call, we were there about 30 hours. And usually that was every third night in the ICU, for example. And when we would do night shift, it was 12 to 14 hours. And that was, for a couple weeks at a time, and then a couple days off and a couple weeks at a time, like that.
Do you think the 30-hour shift was a positive or a negative thing? Because 30 hours is a lot of time to be on. There's not another job I can think of, not even fishing and
Maybe firefighters take long shifts too.
Yeah, but... Okay.
But I think it was very good for learning, because sometimes it's in those off hours after everybody else with a normal, 9 to 5 style work schedule has gone home, that there's an issue with the patient, or that you need that critical thinking and your attending or senior resident is not around. So it really forces you to learn while you're working. So I think that's helpful. I also think that it gave the residents of my generation and the people before us a level of discipline and work ethic. And I'm not going to say that younger people don't have that, but I know that we felt strongly like, no, we're going to work and we're not leaving till it's done. And whenever that is, it is. So I think it was really helpful for that.
Don't worry. It's 12 hours now, I think. You'll be okay. Right? I think it's 12, maybe 8. It's probably 4 hours.
I think
you don't have to worry about it.
I'm not sure. I know most of the stuff is 12 hours. I don't know how they do with the overnight calls now.
They probably get a hotel or something. It's a new world. That's on me, not her. I think, the traditional route of medicine is now, and this is all up, there's a few different things. The main things in the media has more to do with who's practicing medicine. But I think it's important too to kind of talk about where medicine's going and what's kind of happened to it. So, I've seen this from the other side, the company selling side, and seeing that physicians year in, year out get paid less and less and less money per patient. So in order to have a staff of 30 people, you have to see X amount of patients just to pay the lights, right? And so I know you did an interview with some people like that. But most people go and join a hospital, join a practice. What's a traditional route for a physician, and then kind of like what did you decide to do instead?
So most internal medicine residents will, if they're not going into a subspecialty fellowship, like a cardiology or endocrinology, something like that, they will likely go into either hospitalist medicine, which is taking care of the patients that are being admitted to the hospital through the emergency department and taking care of them in the hospital only, or they'll go into a clinic outpatient role, where they usually work for a company, or sometimes it's these financial private equity companies that own these practices. And it's a little bit like you mentioned, there's a sense of a factory component sometimes, because you do have to see a lot of patients in a day, so the amount of time you get to spend with people is quite limited. I would say less and less people go into private practice, and even fewer would go into solo practice, because that's kind of the unknown. And I would say that physicians as a whole are not really trained very well on how to start your own business, or much business savvy in general. So it's tough to do that without the background.
I think, one of the things that is going through Congress now is looking at how mid-levels can help, because people are not going into primary care. And they've kind of created their own problem. And then the common folk and people that want to see a physician or want to get healthier or are not being healthy, it's really hard for them to see somebody. And we've kind of created this big problem. And now people don't want to go into primary care because monetarily, you're going to school for 10 years, more or less, between trainings, just to become family or internist.
So it would be at least 11, because you have 4 of undergrad, 4 of medical school, 3 of internal medicine residency. If you get the honor to do a chief year, that's another year, so 12 years. So it can be long. If you do a longer residency, surgery, it could be 5 to 7 years before you're done with that part of it.
And so what I think is happening a lot is, if you need to pay for undergrad and you also have to pay for medical school, you're $500,000 in debt. And I know it's gone up some, but a hospitalist is making $250, $225, and they've been going to school for 12 years. And there's some people that are making more than that, going to school for 4 years. So I think what's happening is the physicians are going to more specialized areas. And now we have a shortage of primary care. Also, they have to see 60 patients a day, which is not what you're trained to do. Am I correct in thinking that way?
I mean, ideally, if you go to a great medical school and a great residency, they are training you to really kind of get to know the patient and be able to help them. You can't do that in 4 minutes. It's hard to have a conversation with somebody, examine them, review results, and guide them in 4, 5, 10 minutes even. So the goal is to train you in the old school medicine way of spending time with patients, but the real world doesn't have a good space for that in the primary care world.
Can you kind of explain what internal medicine is? Because I think most people don't understand that, and how that relates to primary care, and who else is a primary care physician.
Sure. So internal medicine is what you would classically think of as an adult primary care physician. We are trained to manage the patient as a whole. So everything from acute illnesses that come up, strep throat, colds, flus, to treating chronic medical conditions such as high blood pressure, cholesterol, thyroid disorders, kidney disease, all of that, and recognizing when we need to kind of seek the expertise of a specialist or further testing for those things or further management, and also for prevention of illnesses. So screening for different cancers or different illnesses are kind of the bread and butter of primary care, of the life of an internist.
And then from internal medicine, people will specialize in a different organ or region, and that's like our pulmonologist or cardiologist, correct?
Exactly. Mm-hmm.
Okay. So I think you're able to see the person internally, right? Internal medicine, and look at their organs, make sure everything's healthy. Preventative medicine, if you had the time. We just talked about not having the time. So you kind of came out of school, you came out your chief year, and you kind of went against the normal route, especially for someone straight out of school. You decided to take a kind of a different path of medicine. And I think it's actually a little more congruent to what you were trained to do, which is not real world. And I think this is what has so many people upset, is it's hard for them to see their doctor. And so they rather only go when they're sick. Then they get upset because they can't get an appointment. By the time, they're probably better before, if it's a cold, before they get an appointment. And then they get 3 to 5 minutes either with a physician or mid-level.
Right.
So I don't know if that affected your decision on where to go and what to do, but can you kind of talk about like how you didn't go into a factory, which they're important because that's basically most of primary care in the United States, but why you decided to go in a different route?
So yes, I realized originally, actually, I thought I wanted to be a cardiologist. I loved that module during medical school. I loved cardiac patients and taking care of them in residency. I did an elective in cardiothoracic surgery, and I loved being in the OR and, you know, helping crack open chests and put them back together and very cool things like that. So I love all of that. I didn't love the lifestyle associated with being a cardiothoracic surgeon. I thought that would be tough for somebody who wanted to have a family and had kind of the goals I have for my life. But I did like the heart a lot, so I thought maybe I'll be a cardiologist. And then I realized I like other things in internal medicine besides just that. So I was interested in more than just the cardiovascular diseases and helping those patients. So I realized I needed to go into primary care so I could do all of it. And I was lucky enough to have mentors at UM that understood that I didn't want the traditional clinic type job, that I wanted to be able to be more of what I would call an old school doctor that got to know her patients, spent time with her patients, maybe even visited their homes and did a house call for them. So I was able to do an elective with an office that did medicine like that in Miami, of which there are few. And I loved it. So I decided that that was definitely what I was going to do right from the get-go. And I went into a practice similar to that, like a cash pay small practice where you can really spend time with people and really kind of try to help them on a personal and health level. And I loved it, and it was wonderful. So then I decided that I wanted to continue doing that kind of on my own terms with my own practice.
So I think you know, I don't know if the statistic still holds true, but I recall when we used to recruit in the sales world, I used to talk to all the fellows and try to help them find positions. I was a sales rep in Miami. Everybody wanted to stay here or come here. That the normal physician spends about 2 years at their first job. So you probably went in there, you're trained to think that that's different, but the stats are the stats and they usually hold true. So you went in, joined a practice, right? Because why did you join a practice instead of starting a practice?
Like we said before, that wasn't even something that came across my mind, to be honest, to start a practice, because we didn't have the business education background knowledge. What does it take? What are all the logistics? You know, it takes a lot of money also to rent a place, hire staff, get equipment, get rooms. I mean, this is something that it's not the first thought you have when you're graduating residency. So I thought the more traditional approach is you join an established practice that's doing it right, and hopefully you learn and you stay there and you flourish. And that was the goal.
You retire and everything's great, right?
Of course.
So you know, everybody, especially online, they're always, oh, this just worked for me, you know, and so you have a plan, and you know, 10, 12 years in school, you have this plan, you're like, I'm going to grow old, that's great, I have this great practice that accepted me because I have this wonderful resume, and then you decide to go out on your own, again, against the grain, doing something, like life threw something at you, and you made a directional change. And so how was that opening that, like, how did that go?
So
opening this, I should say. We're in Pure right now. So
yes.
Opening Pure. Well, we're in location number 2. Let me start there. So you started in Pinecrest.
I started in Pinecrest and got a 2-year lease there because I knew that that wasn't maybe the final location. But it was a great location. I had a lot of patients that lived in Pinecrest, you know, so it was actually a good place to be. But it was super exciting and challenging and scary and all of those things all together all the time. A lot of hours. So if I thought I spent a lot of hours in residency, I spent more opening a practice and being available to patients than I ever thought would be the case. but it's the most rewarding thing. I usually think of it as like my first baby. So, and here we are.
Did you ever have any doubts?
I think occasionally everybody has some doubts, right? You know, oh, is this going to go okay? Oh, you know, am I going to be able to grow this? Oh, am I going to be able to get a bigger place, a final beautiful office? I don't know, but not true doubts about what I was doing, because I felt happy going to work every morning, even if I was seeing one patient or had 1 or 2 phone calls to make that day. So I knew I was definitely doing what I needed to be doing.
And I think that's important too for people to know. It's that you're doing the right thing, you're doing consistently, and over time you kept pushing forward, and that grew because people knew you were doing the right thing. They had, oh my God, my doctor spends time with me. Oh my God, what a great doctor. And that started, I was able to witness this, so I know. And that started a little bit of a wildfire. And so you started to see 2 patients a day, 3 patients a day. And I think the problem nowadays is people are like, oh, you can kind of go the traditional route. You can jump into a practice or jump into a business, and then you're busy because a company has that for you. A practice is probably already ramping up, has that for you. And so people want what they want now, but then they want more than they have. And they don't see that the hard work it takes to get to moving to location number 2 in Coral Gables, seeing, which I know for you is very busy, 4 to 12 patients a day, which for this kind of concierge medical practice is really busy. People don't see that. Like, there was 2 years of you seeing, maybe towards the end of that, a handful of patients a day. Mm-hmm. Towards the end of 2 years, it got up to 3 to 5 patients a day. And then the second part, I'm going to just lead, so I'm going to fast forward. So the Pinecrest lease is coming up. One of your patients you start looking for places to lease, correct?
Yes, and one of my patients was helping guide me in that. Happens to be a developer and knew of a lot of places, has built a lot of buildings, and helped us find the right place that was available and amazingly located. And then another patient who's a banker was giving us the pros and cons of leasing, and said, really, you should buy if you can, because it makes more sense to own the space if you can. So with their guidance, I think we were able to find the right place and purchase it.
Yeah, I remember, because I remember the leases were, when you ran the numbers, it was like the same, mm-hmm. without all the stress of building out or buying and qualifying, but it was expensive. And then these are, again, the decisions we make that change everything. And once doctors and restaurants are very similar. You have to kind of stay like in one location. Once you move that location, most places fail. So as a real estate owner, as well as you are, that's the best client to have. That needs to stay put, and you can increase rents, and you can automatically put that in there. And year over year, it gets better and better for you. So I know that wasn't your intention, but you kind of got guided by your clients, and you kind of saw that it was financially equal to do the move, which ended up being, I don't think you knew that. They helped you. Mm-hmm. And then it was one of those, again, little fork in the roads that led to like a much better decision where you own your space and you have control of it.
Right, absolutely.
You don't have a landlord, which is kind of like having a boss. And sometimes, look, not everybody should be an entrepreneur. Not everybody should be their own boss. But I think people that want to break out on their own have to understand there's different strings attached, whether it be real estate, whether it be having a boss. Some people need to work for people and some people can't. I'm not the best employee. I will work very hard, but I work so hard. I used to work so hard that if my own company was providing the friction, I would get upset, because why, if I'm trying to do what's best by my company, why would you not help me, right? So it's kind of nice that you ventured out on your own. So now fast forward to this. So I kind of want to get into a little bit more what's cool in medicine now and what's kind of going on in the medical world. Sure. You come here, and we're going to go one more thing. So you end up getting this through, how did you get the loan?
Oh, I did an SBA loan.
right? Which any people starting a business, I think it is a pain. They might as well ask you for your blood, your hair, your first dog, your first child, whatever it is, your genetic genome. It is insane, the paperwork. But if you're trying to really start a business and you're doing what's right, I wouldn't tell everybody to jump into get an SBA loan, but it's an awesome opportunity through the government and the banks. It's funded by the government for you to start your own business and get incredible funding. I do remember one thing. Back then, I think things have changed. It was like, we think your mortgage is going to be this. Do you recall this?
Yes.
I'm going to let you finish.
Well, it was a variable. Is that what you mean? That it was like a variable?
It was kind of like when you went to closing, and now they have to be much more accurate based after the two.
Oh. Mm-hmm.
But I remember you moved into this spot. It opens up, and the first mortgage comes, and we're looking at it like, oh my God, this is way more. This is way more than we had anticipated. Do you remember that?
Not really. I may have blocked that one out.
Oh, I do. I was like, oh my God. And I think I started working harder. I was like, holy crap, this is the craziest mortgage ever. The other thing I think people don't understand you sacrificed, how long did you not get paid while you were starting a business?
Well, I think the first 2 years, my medical assistant definitely got paid more than me.
For sure. I remember it was a big victory when you got paid a bit. That's her.
Yeah.
And, so here you are, you have this degree, and you have wonderful staff. There's nothing wrong with them getting paid. And it took you years and years to get to a normal physician income. While all your friends, all your colleagues are at a hospital making, whatever it is, $200,000 a year, back then, $180,000. And you put a lot of sacrifice in to kind of build this up.
Those are the trade-offs, and then I get to come to my own place and make it the way I want and be able to take care of patients the way I think they should be taken care of. And I wouldn't do it. I would do it again exactly the same way. I wouldn't have it any other way.
So I kind of want to talk about how you and Pure kind of differentiate on how you approach the treatment of patients here, and how that's, you can very briefly go, versus traditional insurance, but however you kind of want to explain that.
So I think you've touched on a few of the points already. Our current medical system makes it really hard for patients to have access to their doctor and to get to know their doctor, and for their doctor to get to know them, or even for them to be able to see a physician. All of those things are hard. It takes time. You call offices for an appointment and nobody answers the phone. You have to leave messages. They give you appointments months in advance, and they'll cancel them on you, or you can't work with the insurance to get something approved, and everything is difficult. So I think that's a big deterrent for people to get medical care, especially preventive medical care. So they just kind of hold off and say, well, if there's a fire, we'll put it out. And traditional medicine is geared towards putting out fires. So I think what I wanted to do was create a place that was the opposite of all of that. I want to get to know the patients, have the patients get to know us, feel like, this is a second home of sorts where they know everybody, they can come here and get everything taken care of. They don't have to go to a Quest or a LabCorp to get blood drawn. We have great, phlebotomists that can do it here. We can go to their house if they need us, and I can spend time with them. So I can, spend 40 minutes, an hour, 2 hours, whatever they need, and really be thorough in not just putting out a fire, but preventing illnesses and optimizing their health. So the goal of the practice is to kind of meet people where they are in their health journey, evaluate it with them, and give them a plan to make it better, and then to optimize it, and then continue with them to keep that optimization going. So in doing that, we want to be really up to date in terms of technology, testing, whatever's out there, the new the new discoveries in medicine, so that we can offer the best medical care possible and not be too close-minded on new things, right? Not say like, oh, these supplements you're telling me about that everybody's reading about in the media, or these things you're hearing on podcasts that everybody's talking about, well, they don't fit into my traditional residency training, so I'm not going to talk to you about them. No, we learn about those things. I did a 2-year course in functional medicine with the University of Miami when I was already working, to be able to have more knowledge on those things.
Use these supplements, eat this food, and they have all this massive following?
In a way, yes. There are some very bright, very knowledgeable people giving very good information online. but it's hard to tease that out from the people that are giving mediocre information or sometimes misinformation and extrapolating data that you can't go, 1 + 2 doesn't equal 8. So I think it's hard for a layperson to make sense of it, and it's hard to know what's what and what's fake news, like they say. And sometimes it's hard for us as physicians to do it too. We really have to do the research and see what it is. So, when friends of mine send me little clips from podcasts or articles about take these supplements and it's going to decrease your risk of Alzheimer's by 40%, I'm that, nerdy scientist that looks at what was cited in the article and reads the actual study and says, like, actually, that's not it. It's going to decrease it by this much, and nothing is going to decrease it by 40%, that kind of thing. Just to kind of be more realistic with things. I think it's hard in the environment that we're in and in the access people have to social media and to different vocal authorities or semi-authorities, as you would say.
So one of the comical things from that talk of me going down the full body MRI is now there's about 5 venture capital backed companies doing full body MRIs. Mm-hmm. And so it's just interesting. I also think sometimes the excuse is you guys don't have time because you're so busy seeing X amount of patients. The hospitals are putting you through, so I understand, and I want to be compassionate towards the physicians because it's really hard to get there and get that MD or DO behind your name. So I want to be very compassionate, understanding. But also I think sometimes that closed-mindedness is what allows the internet to take over.
Well, yes, physicians, like anybody else, we can be closed-minded, or certain people can be closed-minded about technology or new things, right? Sometimes people don't like change. And so those things are new and change, and it's a lot. However, a lot of people do it from a good place. Our Hippocratic Oath is first do no harm. So if you think there's a test that might not give you a lot of benefit, but it could potentially scare the patient with something that you see on there that they're going to worry about, that they have to get biopsied, that then is nothing, maybe they see it from that perspective. But you also have to open your mind and say, but can we get benefit from it? How can it be used in a safe way that doesn't harm anybody and that gives us useful information or that can help save a life? So I think people need to be more open to balancing all of the information.
I think that's interesting, the do no harm. I think, and I've spoken about this out loud, so I have no issue saying this. The do no harm, it's better to kind of stay in the box than it is to jump on something that is not clinically backed. So the do no harm, I'm kind of internally almost laughing. It's like do no harm and make money. And so a lot of non-physicians are coming out and making money while the physicians are behind waiting for the data. And I kind of want to talk about the preventive side of that. So I kind of touch base on the full body MRI. So talk about some things people can do. So there's a lot of buzz going around. I think some people have done a really good job of getting some information out there. And some of it's good and some of it's bad. Or some of it, I wouldn't say bad, has no clinical foundation. So there's a couple people you and I talk about often, and I'm kind of glad that they've come out and started trying to educate the community, because the community can't get to and spend time with a concierge physician like you, where I get to ask you, come to my appointment, spend 30 minutes for you, and be like at the last 5 minutes, I listened to Dr. Pia Tia, and I read his book about longevity, and I want to talk to you about it. So talk about some of the things that you do or have been doing for a long time that kind of go in line with what's going on there and what people are educating themselves on. I think the best one to kind of start with is one of the, I think he calls it the 4 horsemen that can take you out. And let's start with cancer and the screening and what can be done to kind of look into that for someone that's looking to live a longer, healthier life.
Sure. So yes, while like you said, some people are out there just to kind of jump on the newest thing, regardless of its accuracy or data or anything, and just make money. I would never do that. So when I adopt something into my screening protocols or into recommendations for patients, it's because, like I said, I'm reading all the data and I'm researching it, and I think it has real big value. And I think there's a lot of things now in the cancer screening world that fit into that category of scientifically valid and useful and helpful for the right patient. What does that mean? There's two types of patients. One type is very proactive. You know, I want to screen and I want to find, and if I find something early, I'm going to do ABC to treat it, or XYZ to screen for it. If I'm at risk for something and it's not going to ruin my quality of life. That's a great patient for preventive screenings and going that extra mile to find something. If you fit into the other type of patient.
What preventive screenings are good for that patient?
So for that type of patient, we have a lot of options. We have something like the whole body MRI, which the newer ones are faster and less cumbersome and that kind of thing. And they really look, you know, mostly head to pelvis for any tumors, lesions, malformations that may have been there your whole life or may be new. So if we find something, we can understand that it's there, and if it needs to be further investigated, then we can, you know, hone in on the specific testing or biopsying or follow-up or anything like that. And that can find cancers that are very small that wouldn't otherwise affect your blood work or give you symptoms. So in some cases, it's found people's tumors that have been treated and, you know, people are cured and in remission, which is amazing. There's also blood tests that are newer that look for circulating tumor DNA. So this is looking for fragments of tumor DNA in your bloodstream that are released from small and medium and large tumors, and they can be found in a simple blood draw. If it's found, it tells us, you know, this is most likely from, let's say, lung origin, lung cancer origin, and then we can do the specific testing to follow that up and make sure that there isn't anything, and then you would kind of monitor it over time and do, you know, more in-depth preventive care to make sure that they don't develop anything. So I think those types of screenings are great. Also, if you have a family history, or if you're worried about your genetics, you now have access to full, wonderful genetic panels for cancer risk, cancer genes. You know, you don't have to do your whole genome, but we can do that. But you can do just like a cancer panel from one of, you know, the top companies that do it right, and it'll tell you if you currently inherited or developed any abnormal genes that would put you at risk for a syndrome or a cancer, or that would put you at risk for when you have kids to pass that on.
Is that okay? So those are the three you would recommend for someone that's proactive or has, and then kind of in the middle is a family history.
Right. So the genetic testing makes a lot of sense for certain family histories. You know, if there's a lot of breast cancer or colon cancer in the family, that kind of thing that we know can be very genetically influenced, that would make a lot of sense.
So I think this is an important point too, and I want to make sure we emphasize this. If you have a history of cancer in your family, that's covered by insurance, correct?
Yes. So not always, but almost always. It can be covered by insurance.
For the genetic panel only.
Right.
I want to be very specific. This is not even a question. So that one. And if not, if you're doing it for because you want to know and have knowledge and be able to prevent these 4 pillars of doom, potential doom, I should say.
Right.
You could pay for it cash. And it's not even that much. It's like $300 or $400, something like that, right?
Yeah, I think it's like $250 or something like that. Yeah.
Okay, so that's like a super entry level for anybody that wants to be super preventative. Now, I already know the answer for the next 2, I'm pretty sure. The one that does the tumor in the blood cells is still not covered, correct?
No, that's not covered. It's covered if you have cancer and they're looking for like a recurrence. Sometimes the oncologist will run that test to see if there's fragments of the recurring tumor. That would be covered, but that's kind of the only case.
That's like somewhere $800 to $1,200 or something, right? I forgot.
$1,000,
$1,200.
Yeah, it's in the like $1,000, $1,500, $2,000 zone, but yes.
And then above that is going to be your full body MRI. That's
Right.
the $2,500 to $3,000. That is not covered. I already know that.
Right.
That's not covered. That is people are being ultra preventative.
Right.
I think this is also interesting too, right? Because you just said something that I think is really wrong with our healthcare and wrong with the way. And kind of, I think you said it's kind of how you're trained. Because you have people come to the hospital, you have to handle them acutely and take care of them. I think this is one thing that's talked about, and I don't know if he coined it or not, but this is medicine 3.0, right? There's things that are out there that most people don't have access to, but if you have some cash, you can do. There's some things that if you want to take control of your health, you can go and do through a provider, get a quick little, if you have history, or if you don't, and you want to make sure and you're being healthy and you're getting started in your career and you want to know your genome for cancers, most people can pull off the $200 to $400 in a few months and go ahead and do that. So those are the three main tests you use. Is there anything else that you utilize besides when you find something? Obviously, you have, you go down whatever your deductive reasoning is and whatever you need to do for that specific cancer. Is there anything else people can do, especially if they don't have the means?
So yes, so covered by insurance, almost always, are the routine preventive screenings, your mammograms, your colonoscopies, even a non-invasive stool test for colon cancer screening called Cologuard that we use a lot in people at low risk. Other screenings like that are well known and vetted by insurance, and those are going to be accessible to pretty much everyone. And also the blood work. So we do regular annual blood work on all of our patients in our executive physical. That's part of the concierge membership, where we look for highly sensitive inflammatory markers that are usually not checked in other people's physicals because sometimes the insurance won't cover it, or because sometimes you don't have a diagnosis for why are you checking this. And I personally have found, fortunately and unfortunately, several cancers just because the inflammatory markers were off. And then we go hunting to find out why, because I don't want your body to be inflamed. And if there isn't a clear reason, we have to find the reason.
And so I think this is unfortunate that not everybody has access to this. Because if you're going to take healthcare in your own and you're going to listen to people online, you have to understand what you're looking to do. And so you can demand some of these tests, and I think that's important because the average person is probably going to a regular primary care, so they want to get these tests and whatever they can get to kind of understand their health, so they can plan out their own executive physical or their goal for the year in a concierge membership, and they have to take control of that. So that's one of the main things, and I think one topic that's really important is people are starting to get these cancers earlier, although insurance only covers it at a certain age group based on the data. The breast cancer, for the most part, and I just found this out recently, most breast cancers are, I don't want to take this word lightly, are easier to treat than other cancers. And most colon cancers are highly preventative because it's a slow-moving cancer. And they have really, really, probably the best testing for those two. Am I correct in stating that?
We have great screening methods for those two, yes.
But if you're not going to the doctor in your 30s, which we're starting, we, meaning them, the physicians are starting to see earlier onset. And then if you have a history of rectal, colon
cancer in your family, or polyps or something like that.
Yeah, like they're starting to see before age of 40s when insurance starts covering. So you really need to start thinking about these things and finding out if your insurance does a Cologuard or whatever it is, and figure out like, okay, my dad had this. Okay, I'm at a higher risk before 40, so I should go get at least the blood test, the stool test one, right?
Yeah, so absolutely. There are, most breast cancer screening now in the United States starts at 40. But if you're at high risk, and this is something your doctor can do and should be doing for you, is helping calculate if you're at high risk. It's something called the TC score. It gives you your lifetime risk of breast cancer based on a lot of factors like how old were you when you had kids, and did anybody in your family have cancer, and have you taken birth control, things like that. And it's an algorithm that gives you a percentage. If that percentage is 20% or higher, you should be doing earlier screening and more than just a mammogram. You should be doing a breast MRI every year. There's a lot of extra screening we can do when patients are high risk, but if you don't find out your true risk, or you're not going to the doctor and you're not talking about these things, you might not get that. Same thing with colon cancer screening. It used to be at age 50 in the United States, and then the guidelines have moved to 45 because we're finding polyps and cancers earlier. But 45 for some people is still too old. If you had a family member that had cancer at 50, you should be starting at 40. So there's a lot of earlier screening, regular screening that should be done too.
So what I took out of it, the layman, women, get your boobies checked. Boys, get the backside checked. I'm going to move on to a hot topic that you've rolled your eyes at me a few times. We're just going to jump right over to the back part. Obviously, if you're not in good health, you're overweight, you're not taking care of yourself, there's a bunch of cascades which internal medicine is highly qualified to look at. You look at all the internal organs, how they work together. You have bad heart health, you have bad health. The thing is, you don't really feel that. You may be tired, things like that. But I'm going to jump into a hotter topic because I don't want to we can go further if people are interested in how the heart works and all that, but another time. ApoB. I'm just going to throw that out there. Mm-hmm. One time I listened to all these podcasts, so I'm guilty. I go, hey, Dr. Miranda, did you check my ApoB? I'm sure I'm not the only one. So I just want to throw that out there. And I would love for you to give me the response you gave me the first time I asked you about
Well,
this.
I can't remember verbatim the response I gave you, but we check ApoB along as one of many cardiac risk markers that we check annually and on our patients in their physical. ApoB is associated with all bad cholesterol. That's an easy way to think of it. ApoB bad. So if you have high bad cholesterol, your ApoB will be high. It is not the be-all end-all number for your cholesterol. There's a lot of other things to look at. Your actual bad cholesterol level, I always say L for lousy, your LDL level. And not just the level, but what do those particles look like? What size are they? How sticky are they? We test for all of that because we look at the particle characteristics and sizes and numbers, all of it. We also want to look at your lipoprotein A, which is more of a genetic influence on cholesterol, and that puts you at a separate risk for heart disease than people who don't have that elevated. We also want to look at your high sensitivity or cardiac CRP level, which is an inflammatory marker that is an independent risk marker for heart disease. So there's a lot of numbers we look at, and ApoB is just pink, one. And I know it's like so popular now, but it's not the only test you should get.
Not everybody tests for it, though. So just
Hardly
hardly
anybody tests for anything outside of the basic total bad, good, and triglycerides.
But to get a full picture,
you
wanna
should
see
do a lot
all of
more.
these,
Yeah.
everything you just spoke about.
Absolutely. Because my goal is not to put out the fire when you have a heart attack. It's so that you never build up the plaque, so that you never have the risk, so that you don't have any problems.
Is that what you mean by sticky, the LDL?
Yes. So the more inflammatory the bad cholesterol particles are, the more likely they are to stick to the inside of the walls of your arteries and create these plaques that are the reason why you have risk for heart attack. Those plaques get unstable, they break, they go downstream, they clog the pipe. That's a heart attack.
What if it goes upstream?
It doesn't go upstream.
Okay.
Yeah.
Fair enough. So I think that's the one last thing I want to go on cardiac. So, hey, Dana White, you don't have to go to a doctor anymore. Just listen to Dr. Miranda. You should probably come here, though. I can't believe he said that. I listened to him again before I came here. He's like, I'm never seeing a doctor again. And I want to touch base on that, too. I don't know. Did you get a chance to read into that story?
I think it's an amazing transformation he's made with things that we talk to patients about all the time. Things that we screen for, we being my practice, right? The providers here in my office, that's what we check for. Maybe not in a regular doctor's office, but you have to check for these things, and you have to talk to patients about diets that are going to help improve their metabolism, help them burn fat, keep their muscle. You know, in his case, ketogenic diet, perfect. For other people, it's other diets, intermittent fasting, different things you can include. Do you methylate well? Are your numbers where they should be? And how can we optimize it? And I think if you're able to help people do that, it's not, you know, for me, it's not like, I don't know what one of the articles I read said it was like cataclysmic. I mean, it's not cataclysmic. It's like the stuff that everybody needs to be looking at so that we can all live longer, healthier lives.
So I love Dana White. I really do. I think he's great. I love the content. He doesn't care. He can probably beat everybody up. And I'm like, I'm seeing this, and he poo-poos on physicians. And I was like, okay. So I looked at it, and I'm like, okay, you're falling asleep. You have a CPAP machine. You're tired. You have no energy. And then I think, and I'm glad he did the transformation he came under. You know, and I guess for whatever reason, he went to, do you want me to say it, guys? He went to Gary Brecka, and that's fine. He went to the wrong physician. A man with that kind of means can go to anywhere. But I think where he made, and I think everybody can learn from this, he made a commitment to be healthier. He literally changed everything he needed to do, whereas he was being put on meds because he wasn't taking care of himself. And those medications are going to lower his risk of mortality.
Yes.
Dying. And I'm glad
or living, but really badly.
Which he talks about.
With a heart attack, with all these other things.
He talks about it's about living a quality of life.
Of course.
Like there's one thing, you know, if you want to live older and be able to walk and see your grandkids and all that, I think that's one of the most important things. I do have to give some credit to you. I know you do that inside here. You don't have time to do this. I wish you did. But I'm glad people like Peter Attia do this, and they get that out because it allows people to start looking for people like you. And I think where Dana White went really wrong is saying, I will never see another doctor again. And I think you said it earlier, like every profession, there's good lawyers, bad lawyers. There's good CPAs and bad CPAs. There's great physicians, and even bottom, they do their best, right? It's who do you see that can help you? But at the end of the day, as a patient or as a person, if you don't make that decision to take control of your health or listen to your physician, you're going to have what you have. You're going to be on meds. And what happens a lot, especially in traditional medicine, is people wait for something to happen. An alarm goes off. They have a mild MI, aka heart attack. They have something, they faint, they this, and then they get their stuff in order. Or they don't.
No, it's true. I mean, but that's with anything. A lot of times people are stuck in their routine, good or bad, until something shocks them out of that. And unfortunately, for most people, it has to be a bad outcome for them to be moved enough to change. Sometimes it's a good outcome. Sometimes it's being inspired, or, you know, they fell in love and got remarried and now they want to be healthy for their young children. You know, things like that. Amazing, wonderful. Whatever it is that brought you to the place where you want to make that decision of, I want to be healthy now, perfect. Now let's figure out not just what do you need to control your numbers, but how do we fix this, fix the underlying problem so we can get rid of medicines. I'm a big proponent of, if you need a medicine, you need it. But if we can figure out how to get you off of medicines or prevent you from having to take medicines, why not? Because the goal is that you should be healthy, and it should be all about your quality of life.
Yeah, so I listened to that one more time, and again, I respect you, and don't beat me up, Dana, or have anybody else beat me up. But this black and white, yes doctors, no doctors. No, that's not the way it is. You need to find a way to get your best outcomes. So another thing I think that anybody can do, that I think a lot of people don't do until something happens, which I want to kind of touch base on, is a very inexpensive preventative heart scan that you can do.
So I think you're talking about a cardiac calcium scan, and we use that a lot. I think they're very helpful. Generally, people age 40 and up, or it could be younger if you have other risks too, but the data is for ages 40 and up. Looks at if your arteries have any calcified cholesterol plaques already in them. So if it's a score of 0, whistle clean, no calcified cholesterol plaques. Then the score can range from 1 to my highest score that I've taken care of a patient for is just under 6,000, which is the highest one I've ever seen, much higher than a lot of others, but the score goes up from 1. So it's a good screening tool for risk stratifying patients, meaning I can tell you, hey, if your score is 0, you're generally considered a low risk patient if everything else looks good. You're not smoking, you're eating right, you're not overweight, your blood pressure's okay, you don't have prediabetes or diabetes, all the other things that increase your heart risk. If your score is high, we're not going to get rid of those plaques with diet or exercise or anything else. So if you have a high score, 100 or more, almost every cardiologist in the US would probably put you on medication and or figure out what do we need to do to be really strict with your numbers as well. If you're somewhere in between, then that's where, depending on how aggressive your doctor is or how aggressive you want to be, or together what plan you make. You know, there's some cardiologists that like the score of 30 as their cutoff for medication. And there's some people that I wouldn't even be happy with a score of 10 because their lifestyle doesn't allow for health enough that I'm not, you know, worried about that person, and that the 10 can't become 50 next year and get worse and worse. So it's a great tool. It's non-invasive. It is a CT scan, no dye. And generally insurance doesn't cover it, but it's about $100 at almost any imaging place.
Yeah, so I think that's another great thing someone can do to prevent, because the heart is usually what creates a certain cascade. I will play bad cop because you're obviously the good cop. I tell people all the time that do not have the means, that are older, that have stress. I'm like, they don't want to go waste their time at a physician, or they're getting the very normal blood test in this. I'm like, go get that done. I go, and then bring it to your physician.
Yeah, why not?
I tell them all the time. And I've actually had with some people I highly regard, very intelligent cardiologists that are like, you don't need that. And then I tell them, and then one of them was actually there, and I'm like, why don't you need that? Ask him. Well, you haven't had any heart problems. I'm like, why are you going to wait for that? And so I think this is a wonderful tool that most people can afford, you know?
For sure.
So I think it's that. You brought up something that I just kind of want to touch base on that has been like buzzing the internet. And I did confirm it with you. I was like, dude, is this what this means? Methylated.
Oh, yes.
Methylated vitamins. I've got sent at least 30 different Instagram reels about, oh man, do you guys offer this? What is this? Are you on this? You guys know about this methylated vitamins?
Well,
Can you ask Dr. Miranda? And I'm like, dude, and the worst is too, I've also listened to a few podcasts with Gary, and again, thank you for putting the information out there, Gary. And I'm almost 100% sure, and thank God that company's behind you and you're getting people educated, 100% sure there's a doctor on your team. I really hope so. I think you even say that. So I want to just like kind of go there and talk about that and talk about like what does that mean and what let's like simplify it for the average consumer so they don't have to go and be like, what is this? And then go to someone's company and maybe buy their vitamins.
Yes. So we don't learn a ton about this in medical school or residency, but I did learn a lot about it during my functional medicine training. So it's methylation is the way that the cell, it requires methylation in order to replicate, in order to regulate DNA, in order to do so many regular cellular processes that we do on a daily basis, thousands and hundreds of thousands of times. And if you are somebody that has a genetic predisposition to have trouble methylating or you can't methylate well, then you're going to have trouble doing all of these things and you're going to have symptoms as a result. You can have deficiencies of vitamins that can cause fatigue, anemia, weakness, all kinds of things. Your mood can be affected. Having a deficiency in methylation that makes your folate levels low causes depression. So there's a lot of health consequences that honestly clinicians, physicians should know about, should learn about, because it can help you treat patients better. And there's data that not being able to methylate correctly can affect the processes that affect our blood pressure. So in blood pressure patients, you should be checking it too. So one of the easy things about this is that this is something that's fixable. Even if your body doesn't do what it's supposed to do with methylation, you can easily take methylated forms of B vitamins and combinations of those, some of which I prescribe to a lot of patients because they're great for energy and everything else.
Like which one?
I love Methyl Protect by Zymogen or Methyl Guard by Thorne. They're some of the highest quality companies and also ingredients that I found across the board. And I'm sure there are others, but they have methylated B12, methylated folate, the cofactors, trimethylglycine, all the things you need so that your body works the way it's supposed to. And in that blood work that we check on everybody once a year, we look for your B12 level, your folate level, your homocysteine level, all the things that would show difficulties with the methylation process and would be an insight to how we can help optimize those things.
You said homocysteine. What does homocysteine show in the body?
So homocysteine is it's another type of vascular inflammatory marker. If you have high levels of homocysteine, you might be predisposed to form blood clots. So these people might be predisposed to have DVTs in their legs, pulmonary embolism in their lungs, or stroke risk. So we want to find those people and see why they have high homocysteine, if it's a true clotting risk, or if it's just this methylation issue, which is reversible and easily fixable.
Does that have anything to do with stress or no?
So I think if you raise your stress level, maybe like you've been at times in your life running on 1,000 at all times of the day, you can increase a lot of your inflammatory markers that way. And I have seen homocysteines that have been elevated, but not to the extent of people with blood clot risk problems.
And not everybody has a methylation problem.
Of course not. Not everybody has a methylation problem, and some people get side effects when they take too much methylated supplements. So if you're listening to Instagram and you're hearing about this and you're like, I'm gonna go take this 3 of them a day just to be careful, you might end up having side effects. People get joint pains, fatigue, dizziness, all kinds of adverse side effects if they don't need it and they're overdoing it.
Because it's overdose and their body does methylate.
Yeah, and it's, too much of a good thing can be a bad thing.
Okay, yeah, stress stress will create a lot of problems, especially if you have poor health and poor habits. So, I think we talked a lot about medical. I don't think, I'm looking here at my notes and I'm like, okay, I think we covered most of these topics. There's a couple more things, I guess, we'll go really quickly through. I think there's a pretty hot topic now about weight loss medications. Ton of stuff out there that they're good, obviously that they're bad. I saw something today saying, oh, the FDA is warning against these weight loss medications. You want to touch base on that a little bit and discuss like what people should be looking for? It's Miami, so people are going to I've seen like basically hairdressers and tanning salons that have a doctor on board and are putting all these things out there. It's so crazy.
But, you'll find all kinds of irresponsible business practices anywhere you look.
Online, Miami especially. Anyways, but I love my town, baby. But
I think
boy, do we know how to make money.
Truly exciting and remarkable that they've been able to come up with medications like this. They've really changed obesity, I think, permanently for the better, and diabetes care for the better. These medicines were originally diabetes medicines, and we found out that those people were losing a lot of weight, and people without diabetes were losing a lot of weight. I'm talking over 20% of your body weight, like significant amount of weight that we haven't seen with other weight loss meds. So they can be used very successfully if you're doing it right. And so, I think a lot of what I saw in the media, what patients would come and tell me, Dr. Miranda, they're talking about Ozempic face, and am I gonna look like this? And I go, anytime you lose a lot of weight in a short amount of time, you're gonna look like you lost a lot of weight in your face. So we gotta do this slowly, carefully, and the right way. Oh, they're talking about losing muscle mass and affecting bone density.
Was it flat butt? Well, bone density, flat butt.
Muscle mass or bone density. But it's because people weren't changing their diets. They were just trying to eat less bad stuff. So let me eat less, but I'm still going to be eating pasta, only pasta. Well, that's not going to help you build or maintain muscle. You're going to lose it. And when you lose weight, you typically lose a little bit of muscle and you lose fat. The goal here is that you're eating a high protein diet, that you're exercising with weight training and everything so that you maintain and build muscle, and you track it with body composition scans so you can see how much fat you're losing, how much muscle you're keeping. And in those cases, we've been super successful. So I actually think that they're amazing.
I think, I've heard, both sides of that. I know some of your clients and patients have gone outside and then come back because they just gave them a prescription to lose weight and be pretty. I think it's interesting. Obviously, when you lose body weight and you're diabetic and you're overweight, that has a lot of positive things that occur, like
profound health effects for sure.
Yeah, which reduce mortality and all these things. It's kind of funny too, the other blockbuster drug, and this is for sure going to be one, if it's not already $1 billion drug, that's what makes it a blockbuster drug. It was like the accidental Viagra. It was for heart. This is like the old story. It was actually for hypertension. It was to help with the heart. It was a nitrous oxide, was it inhibitor? But increased NO2, nitrous oxide, and what they saw, the side effects were profound for sexual dysfunction. And so they changed it over. Same kind of concept, something that was for diabetes, help people lose weight, and now we're utilizing it. I think it's important too that what you kind of just said, people, what does it do? It curbs?
So Mounjaro has 2 receptors it works on. The Ozempics, Wegovy's of the world have 1 receptor they work on, but they all work to help you feel more full, slow down the passage of food from your stomach into your intestines, so you eat less, you're less hungry. Sometimes Ozempic can help with cravings, but I've seen that more with Mounjaro because it affects the center in the brain where those receptors are, that are the cravings, the emotional eating, the disinhibition. So it can affect all of that and make you eat less, regulate your blood sugar, improve your metabolism in that way. And we now have studies looking at outcomes. So we know it's not just about losing weight and normalizing your blood sugar. We see that these people are having less bad outcomes, less heart attacks, better mortality rates, things like that.
And this all comes back together. If your lifestyle, your health, and you're moving and you're eating better, you're gonna have better outcomes. Right. You're gonna take control. I really like the thought, and of course people take advantage of it. I like the thought that you can change what you're eating, but most people still don't. And that's where the problems come out with these medications. And that's where having the right person giving you the protocol is important. You want to change what you're eating. There's an opportunity. Your brain's like, I don't really crave peanut butter chocolate bars from Reese's. Oh my God. I don't really crave that anymore. So let me change that for something else. Let me change that for a berry. Let me change that for a chocolate square. Let me change the way I'm eating. Let me change that so I can have a great outcome.
And that's also a key part of what we do with patients for weight loss, because the goal is, if you just need it for weight loss, I don't want you to have to take it forever. So I want you to put those tools in place in your lifestyle so we can wean you off of it when you're ready, when the diet's right, when you know what your portion size should be, when you're exercising and drinking water. So when you get rid of it, you can maintain the weight loss.
So that program could be like someone that needs to get their health in order, where they're skinny or a little skinny fat or overweight and they have bad numbers. It's kind of like a quick little way to kind of change their lifestyle, get them where they need to be, and help with the brain part and the eating part.
It can be used temporarily very effectively, yes.
Nice little bolus. So I wanted to touch base that because, I mean, everybody, somebody went to like one of these black tie events, and he goes, wow, I was here last year. And he was like one of the mics, and I know him actually. He's kind of funny sometimes, but he was funny this night. And he goes, wow, I guess everybody looks so great today because of Ozempic, which was kind of funny. So you go, man. You go ahead and say that stuff. That's fantastic. I think some of the other things that that people need to kind of understand is like how the social world and daily activities affect your lifestyle. We are meant to be like talking to each other in person, not with these things.
For sure.
You know, we're still tribal. Our brains haven't changed that much. So I think that's an important part of probably having interaction, probably mental health. You have any things to talk about? Because I know that's mental health is a hot topic, but I think people don't look at like where we came from. I always think like we used to be in caves, taking care of each other. Somehow we learned how to make fire. And then here we are, like, dominating the world with our primitive brains.
Well, definitely, I think the pandemic, which, by the way, it's going to be 4 years in a couple months that it was
COVID started.
So we should be like
a vacuum.
I know they call it post-man. It's almost like after death, AP, the watch, which is really
AC
nice.
After COVID.
After COVID, yeah. I was like, AP, I want one, but like, yeah, AC after COVID should be like its own term.
I think the pandemic actually really kind of made that point that we're social beings very, very relevant to people, because people were isolated, right? And in their little bubbles. And we realized how much social interaction we need for our daily health and our mental health. You know, you mentioned in the beginning, is family important to you? Family's huge for me because I value my, what I call like social wealth, my relationships very much. So my relationship with my husband, my relationship with my kids, my relationship with my siblings, and, you know, our extended family, I think is one of the things that adds a lot to your health. And it can be a hard part for patients who don't have great social relationships. And it should also be something that we're all kind of more sensitive to, you know?
And so I think it's important. Find the people that add energy to your life. Don't take it away. Sometimes you can't do anything about it. You may work in a place, get enough skill sets to change your job, and find a place that you feel at home that reduces your stress, because that creates a lot of health. Get your health in order. I guess I don't have a lot more questions for you, but I think maybe one thing we didn't really get into is like, what is concierge medicine versus what people are traditionally used to?
So I think we've said a lot about what it is based on all the differences in what we do versus what is out there for people on a regular basis. But it's providing people with true access to their physician, a one-on-one personal relationship with your physician, and getting the best level of proactive preventive care and health optimization to kind of be your partner in this like health journey of life. So we try to do that for our patients, and also make, you know, be like their health system navigator, helping them get in with the specialists we want them to see, helping them, you know, get the appointment for the MRI that we want them to get tomorrow, not in 3 months, you know, things like that. So streamlining healthcare and just making their quality of life better.
Yeah, and giving them a goal. And then you have like a little bit of a different level where you give someone an annual plan. That's what I think you mentioned it before, the executive physical is, right? Yes,
so we still do a la carte executive physicals for people that feel like they don't really want the extra level of service and like ongoing attention, but they do want some really comprehensive, like one-time look at their health with a plan for the year. And so we're able to do that. You know, it's like a 2.5-hour physical and then another half an hour to really dig deep into the results and hopefully put them on the right path to optimizing everything.
Give them like the blueprint. I'm going to call that our junior membership. That's what we're going to, yeah. So all the people looking to invest into their healthcare, these are opportunities that not just here at Pure Executive in Health and Wellness, that there's other ones in Miami and all across the country and probably all across the world. So if you have those means, look into that. If not, take control of your health. And I really thank you for your time today.
Thank you. This is fun and new.
Thanks a lot. Until next time, it'll be way worse on the bad cop stuff. But thank you for joining me, Dr. Miranda.
Thank you.